Welcome to the next episode of Endoscopy Essentials. We're going into a difficult topic today. It's ESD, endoscopic submucosal dissection in the colon. And I welcome my good friend Jeremie Jaqcues from Limoges, now Montreal. Welcome, Jeremie, and thanks very much for helping us.
Thank you so much. It's an honor for me after all these very famous endoscopies to be here in front of you. I'm quite a little bit impressed, I should admit.
You are famous. So what we will not do, we will do this on a different occasion, is discuss about indications, EMR, ESD, because that's an ongoing battle and evidence is accumulating. We want to start with the decision has been made to do ESD and how to do it. The other question is which lesion to select is the topic of a different podcast later on. So that's just the technical performance. So Jeremie, if we start, there's a lot to prepare, right? So if a patient is scheduled for a colonic ESD, in which setting? In France, it's general anesthesia.
But no, I have also my North American experience.
Yeah,
so, and it works also. In France, it's general anesthesia, and it was, when you help us for the paper, for the randomized trial, it was an important criticism, and it was true because there is a lot of places in the world where access to general anesthesia is difficult. And now I'm in Montreal since 2 months, and I've performed 12 colonic ESD in Montreal. All of them ambulatory, without general anesthesia, only with sedation with midazolam and fentanyl. And I just checked it. Of course, it's preliminary result because it's 12 lesions, but I have exactly the same data at this time. What I feel that, and I was happy to train myself about that since months because I believe in this part, that underwater ESD for this kind of situation will help a lot because my opinion is that the tolerance of the patient is much better because what makes the patient having a bad tolerance is inflation, in fact.
Okay, that's a very good point. I out myself as a fan of general anesthesia, so a right-sided colonic ESD, if necessary, I would do under general anesthesia. And I think every department which is very active should consider taking more general anesthesia, even if not mandatory like in France. So that's a discussion, but probably the answer is probably yes, but not mandatory.
Yeah, probably yes, and probably you will change a little bit the way you do. Because you have some advantage also. I discovered an advantage. Under general anesthesia, we like regularly sometimes to turn the patient, but it's difficult, cumbersome with the patient with orotracheal intubation. With conscious sedation, I discovered that I asked the patient to turn much more during the procedure that I was doing in France. So you compensate some difficulty by other aspects. So I think it's a different way to do. I don't have immediately the same strategy and the same way to go.
Interesting. That somebody who is very experienced can be influenced by the circumstances and discover some advantages. Okay, so that's an open question. What else? How much time do you usually schedule? I mean, maybe you shouldn't take your experience because you're very experienced and very fast. So it's usually
the mean procedure time. It depends what we show the procedure time: scope in, scope out, or injection and of the dissection. If we say scope in, scope out, the mean procedure time is around 90 minutes. But of course, I don't like mean procedure time because it depends on the size. More it's big, more it will take time. So I think all people that do SD should have their own data sheet with their result and about their speed. The speed, it is in generally square millimeter per minute in the literature. And then, if you have a good picture, where you quite have a good evaluation of the size, and you know your speed, you can organize well your unit. And you know that normally, without a huge difficulty and you don't imagine before, for a 5 centimeter lesion, you will take 1 hour and you schedule 1 hour. And if you are a little bit less fast, you schedule according to that. So I think that's something very important. People should know their speed to organize their unit, not to show good they are. It's not that. I don't care about the individual speed of the people. It's not an important endpoint for the patient, but it's an important endpoint for the organization. So it means that we need to have very good picture or movie, and that's not so easy. I don't know it is in Germany. In France, it become not so bad. But for example, now I'm in Montreal. I have picture by very far, just apart, only with white light, and I had big surprise in Montreal since the beginning. I've done Wednesday before coming here a 15 centimeter in the rectum. The people told me it was a 6 centimeter in the rectum. So of course my organization was a mess during this day, for example.
That's a very important and very difficult point at the same time. So what would you require in order to schedule the ESD? Because colon, upper GI, you can have a quick look.
Yeah.
So how often do you think, or in Limoges, how often did you have to scope your patients before?
Unfortunately, because of lack of possibility, we never scope in the colon. We try to scope the rectal lesion for people that come not from so far, because also there is, the impact of the transportation, the cost, the ecological impact, so we try to avoid. So in the colon, we never can, because we don't have any solution for doing that. So we have done, like, a typical report that we ask for the referral gastroenterologist to say to us. We need an evaluation of the size with a picture by far with white light with good inflation to see the macroscopic aspect and the size, and then a picture more close to see some pit and vascular pattern abnormality. Not that I believe a lot of that, but just to organize if it can wait 4 months or if it should be done in 1 month. That's also part of the organization. It is an oncological emergency or not. And then after that, we ask for the colonic ESD, one thing that's very important, it's the difficulty of the colonoscopy. Because that makes the huge difference between colon and all the other locations, that if you have a so difficult colonoscopy with looping, everything, and stability, that change your speed by 2 or 3 times. So that means that it will be much more difficult. And I know this is not the topic and we will not speak about EMR versus ESD, but for me, that's a very good, important element for a selective strategy. I prefer a lot of selective strategy by a technical factor than more than an optical diagnosis, because there is some technical factor I know it will be dangerous and it will be a nightmare for me to do a colonic ESD.
That's a very important point. But, isn't it that any large polyp where the referring feels he shouldn't do it or he cannot do it or doesn't have time or for what reason ever should be documented that way, no matter whether it will undergo EMR or ESD?
I'm sure. All this kind and even more, the polyps that are sent to the surgeon. It should be documented like this. And we should ask the surgeon that if you don't have cancer on a biopsy, you show a picture, and then in the MDT meeting, the expert gastroenterologist in the institution tell you if it is resectable or not. And you will avoid a lot of this primary surgery for benign or superficial lesion. That because we lack this part,
Which is still a big problem.
Still a big problem, and even in France and even in my unit, we do a very small study published in a very small French journal. It was the medical degree of one of my residents, and we analyzed the result of the big polyps found in the screening program by FIT in 2013, because it was the first year that we began ESD in Limoges, and in 2020. And for polyps more than 2 centimeters, we don't change the primary surgical rate. Even from guy that works in my unit. You imagine?
Yes.
So I know a lot of people that say, no, nobody is sending anymore in my unit, etc. No, I trust only the data.
I checked the literature recently. There's quite a few, even recent data, that's still up to 20% of large polyps go to surgery. You think one of the weaknesses of endoscopy is that we don't have any standards of documentation.
Of course.
CT is very different. It's standardized, everybody can look at it. So I think there's a huge room for improvement.
Of course. Yeah.
Especially before therapy. And people should realize that it's very important, especially in the colon, where for a pre-check you need a separate preparation, and it's really important. So that's only something we can work on. In your experience with your main referring physicians, it works. So after a few years, the documentation quality.
Yeah, and I think also that's a big bias, because in fact I think the people that we convince in France to move from piecemeal to ESD and to send as a patient, that are people that are doing good job and that are interested in this field. So these people, you can ask them a lot of things. They are interesting, so they do that. And that's why the number that doesn't change about surgical referral, that's the people that are not interested, that don't care, so they will not do the pictures, they will continue to send, and we don't find a way to save the patient from them, They continue to do like this. So in our network, that works because we are lucky and we have trained them and you have interesting people. But people that are not interested, you don't see their patient because in fact...
And there's no possibility of a quality control? I mean, that's a universal question.
It's a big question. Yeah. I don't know. I don't know it is in Germany. In France, we don't have that. We don't have a lot of quality control like this.
No, we don't. I think no country really has it, at least down to that detail.
Yeah. Who knows in France is ADR, If just is ADR. You only know your ADR in the FIT program. You don't know your ADR in regular colonoscopy. So you imagine moving to quality control about what you do about your big polyps. First, it will be interesting to already know our ADR for the quality of our screening colonoscopy. So we are far.
So maybe if we speculate into the future, that IT would allow us that the entire colonoscopy is documented and then some AI cuts out the polyp, and that's the only way, I think.
That's my dream. My dream is when I speak sometime to AI company, it's please make an AI system that makes the report himself. And the physician has no choice. If the AI say, you have a big polyps, and because we have Cadix, this polyp is resectable by endoscopy, and it is written in the report, and it cannot change, it's over,
But that's second step. First step would be to have a full documentation of the video.
Yeah.
And space is not a problem, etc., etc. But we are far away. So before we get either depressive or too speculative, we now go to ESD. Anything we forgot with preparation? So the assistant table is not. It's a cap.
No, you're true. Your assistant team is important because I discover also that in Canada I have the chance that I have my assistant nurse that grow with us, So, and we work from so many times together that we forget how experts they are also. And I arrive in Canada and I discover that it's new for them. And so my cap was not ready, my coax forceps was not ready. So in fact, we have a checklist in Limoges and we have a specific table where we put all the devices that we will perhaps need during the procedure on this table, that it should be available. Because generally for a nurse, it's not very difficult technically. You open, you close, etc. But sometimes you need to go fast. If you have a big bleeding, you cannot spend 10 minutes to find a coax forceps. If you have a big hole, you cannot find 15 minutes to find something to close it, or a decompression needle or something like this. So that's a part of the preparation that is important. And if you see that you are with a new nurse, for example, I always take time to check that everything is available in case.
But that should be like in the OR. So what's the standard table? Which kind of cap? One cap, a standard cap, or soft cap, different caps?
Yeah, there is a lot of caps. I don't think there is evidence. My practice is using soft cap, the new one from Japan with 4 holes. I forget the name of the company, the Japanese company, and that is available in Europe. So it's a very nice cap. And for some difficult case, I use a STO cap. But for example, for recurrences.
So there should be 1 or 2 caps on the table, and then a needle.
A needle to inject.
A knife. Do you use several knives in one procedure, or just one?
Just one.
Just one.
Just one.
In 90x%.
It's exactly 95% of cases.
Okay.
One knife.
And coagulation forceps.
Coagulation forceps and
clips.
Coagulation forceps. We have some friends that use even hot biopsy forceps for money reason, and I should say they have the same result about bleeding and post-coagulation syndrome than us. So I never do that because I was afraid about the results, but I should admit that in the French database there are very good results, and so it's €10 and it's much less expensive. So in this field I think it could be important.
Okay, good. So that's all?
Yeah, that's all, and clips. And some traction device.
Traction device, yeah. There are simple ones and more difficult ones. That's highly individual. We'll come to that later. Yeah. So that's the table. And then you depending on where the polyp is, you start with a cap already.
We forget one thing. The plate to pin.
Ah, right.
You know why? When I arrived in Montreal, it was the most difficult thing to have.
Ah, okay.
We can buy everything, but this we cannot buy. So we discussed with the pathologist. It takes at least 2 weeks to be able to find the good plate to pin the specimen. Okay. So don't forget that when you begin.
And pins.
And pins also.
Okay, good. And then when you start with a cap.
Always, yeah.
Always.
Yeah.
Because otherwise you would have to go out again. Yeah, exactly. And then you go to the lesion, and how do you then assess which patient position you should have? You probably start left lateral.
I always start left lateral. I insist a lot because that's something we forget from the Japanese that is so important, is the shortening colonoscopy technique. So I even push more to have a perfect shortening colonoscopy when I know that I go for a complex resection in the right colon, because whereas it could be a nightmare, it's just not reach cecum and then pull back and find lesion. You need to remove complex lesion. So shortening colonoscopy and water exchange colonoscopy to have the most important shortening technique. So that's okay. And you know, I take a little bit more time sometimes because I know that I go for a complex resection for the technique of colonoscopy, and that have made me improve a lot for my colonoscopy technique making this resection. So I think it's very important. Then I start in the left lateral position. We go to the lesion.
Which scope? Large channel?
Yeah,
so is the normal channel enough?
I don't know if you can say the name of the company. It depends on the company of your scope.
But what should be the channel size? You should have enough for suction, right?
Yeah. But in fact, we don't have the same. I discovered, for example, you know, my friend Mathieu, we don't have the same strategy. I use classic colonoscope with a 3.8. He used therapeutic pediatric 3.2. But in fact, it's because we have not the same manufacturer of scope. Because he used the Olympus one, the PCF therapeutic, that is great. Because the classic colonoscope are Olympus are larger than the classic one from Fuji that I have, and are a little bit stiffer. I have also the both. I have Olympus and Fuji, and I use the PCFT only for the left colon because I feel a little bit, you know, too flexible for the right colon, and so I move. But for the Fuji scope in the right colon, I will not use the classic colonoscope of Olympus in the right colon. So it depends on a lot of things. So also
do you have one scope or do you have a selection of scopes? If we remain on a
I have a
general
strategy.
level?
Yeah, I have a strategy. Rectum and left colon, it's pediatric therapeutic scope. And since the splenic flexure, now the right part of the transversal, we say classic colonoscope, but because of the name I told you, for this part, because we need to find the scope that will have the good compromise, size of the channel, bonding ability, flexibility, and that's what is nice, and that's why I'm happy to have the possibility to have all these famous companies in the unit, because you know I can choose the best for every location.
Flexibility in retroflexion?
In retroflexion, but also in direct vision, because if you are too stiff, you know, your scope will not be able to go smoothly below the lesion. You have you know, some things that is very stiff and difficult to manage. So it's also important. But if it is too flexible, you will loop.
But wouldn't it be, I mean, of course you have to have your own selection, and you mentioned that Mathieu Pioche has a different selection, so you should tell the nurse your selection. But maybe you should have a second scope just in case.
Yeah, you're right. You're right. And we have a second scope. Generally, it's should we move to a classic to a pediatric one, therapeutic one, and it depends of a lot of situation. For example, when can we need a thinner scope? Generally, it's ileum invasion, appendiceal invasion, or recurrence. Because it's very difficult to reach, and so more the scope is thin, more it's important. There is one thing I forget in the scope that is very, very, very important. It's the location of the operating channel of the washing channel. Because ideally, it's having a working channel close to 6 o'clock and having the washing channel in the same axis. Because you have some scopes, you know, the washing channel is here and the operating channel is here. So when you bleed, you need to move, but you are your forceps that is here, you move, you lose your position, you go back. And so that's very, very, very important also for the choice that I do every time. And I always choose a scope, whatever the manufacturer it is, that has these two characteristics, an operating channel at 6 o'clock and a washing channel in the same axis than the operating channel.
I think that's a very important message, because usually you think scope is scope, and maybe some like the normal one, and others they're pediatric, but you should think twice where the lesion is, how difficult the colonoscopy is. You don't know how difficult the position is. You will learn when you are in, unless you have something in the report. So it's not only the table, it's also the scope. You should think a little bit.
And to take care also about the organization of the unit, about the scope, that they regularly go to make a new tightening, a new tension of the cable, because you lose the retroflexion. And if you don't organize that, you can be in a huge trouble. And I know that 5 or 6 scopes that we use most for ESD, we organize a rotation with the manufacturer to always have good retroflexion ability, because it could become a nightmare, not because of you, sometimes just because your scope is like this for the retroflexion.
Yeah, so check it before you
Check
start.
it, yeah. And
which we usually don't do. So check the scope, how flexible it is, how much it retroflexes.
Yeah.
And if you're not satisfied, take a different one.
Yeah,
rather wait.
Yeah.
Okay, good. Very important messages. Did we forget anything before you introduce the scope or put the scope into, I mean, bowel cleanliness, that goes without saying.
Yeah, of course.
As clean as possible.
And that's a trouble. And we see each patient, or at least by teleconsultation, all our patients before to explain them the procedure. And you should insist a lot about the bowel cleaning. In particular, where now we have more and more lesions and our delay are increasing, because if you arrive in a patient that wait for already 3 months for ESD in the right colon, it's not clean. And so if you don't do that, you go back to do 3 or 4 months after, it could become to be worrisome. And I know that I've made the mistake at least one time to say, okay, my waiting list is too much, I will clean a little bit, and I will do. And I make a perforation, and this perforation was bad, not because it was difficult to close, because the bowel was dirty. And no, I never do that, but I speak even more about that to the patient, because it's okay for a success and for a safe procedure.
But if you are in and the bowel is not super clean, it's sort of dirty, you should probably, depending on the logistics, spend even 20 minutes to clean, right?
Yeah.
And be sure that no dirt is coming out of the valve, etc., all that kind of stuff.
Yeah.
That's almost an extra podcast.
Right.
Okay, so now we are prepared, but we end this one with a cliffhanger. And we come back with the actual ESD in the next episode. Thanks very much, Jeremie.